Welcome everyone on my 12-month progress report on comprehensive therapies of acne, from conventional therapies to microbiome modulation. As you might know, acne is an inflammatory skin condition that affects more than 9% of the global population worldwide. And despite the widespread use of antibiotics and retinoids, sometimes we cannot achieve complete clearance. Systemic probiotics reduced inflammatory lesion count by 10 with a good safety profile, and it had a similar effect as topical antibiotics. So dermatologists are advised to use systemic probiotics as adjuncts in acne treatment, but we need further research to establish the standardized dose, the treatment duration, and the length. My name is Hanna Potra. I'm a medical doctor and a PhD student, and my vision is to get improved care of acne patients. I would like to achieve this by implementation of novel therapies of acne. I have two specific goals. The first one is about investigating the efficacy and safety of microbiome modulation in the treatment of acne, and the second one is about the efficacy and safety of different doses of isotretinoin treatment in acne. Let me jump to the first presentation about the microbiome modulation. As I mentioned before, it is a chronic disorder affecting hair follicles and sebaceous glands. It affects 9.4% of the global population, being the 8th most prevalent disease worldwide. It decreases quality of life. 27.2% of these patients develop depression. It has multifactorial pathogenesis and risk factors, the role of dysbiosis because of the Cutibacterium acnes. Among its standard treatment, there are topical ones and systemic ones, retinoids, antibiotics, hormonal therapies, or isotretinoin. Unfortunately, many patients fail to achieve complete clearance of their acne, so novel treatment options should be used, such as the microbiome modulating agents, probiotics, or prebiotics. The disease activity scores are measured in inflammatory and total lesion count. My aim is to evaluate the efficacy and safety of microbiome modulating agents in the treatment of acne. My clinical question is, which is the safest and most effective microbiome modulating agent in the treatment of acne? I'm working with acne patients, administering them novel microbiome modulating agents, standard acne treatment, or placebo, and the outcome will be measured in efficacy, safety, and quality of life. My hypothesis is that novel microbiome modulating agents are as effective but safer than standard acne treatment, and if this turns out to be true, then novel microbiome modulating agents could improve the treatment of acne patients. We have started with almost 8,000 articles, and at the end we remained with 27 eligible articles. Now let me present my first outcome, the inflammatory lesion counts longest follow-up. It reflects the degree of active inflammation. The unit is the mean change of inflammatory lesion count that ranges between -2.3 to -19. The lower values mean more improvement, higher values less improvement. We included 27 RCTs with over 5,500 patients, and we had high heterogeneity due to differences in study duration or baseline severity. I presented the outcomes in mean change in inflammatory lesion count, the placebo lowered it by 9, the systemic probiotics by 10, topical antibiotics by -12, and topical retinoids by -6.5. They were all clinically and statistically significant. All treatments reduce the inflammatory lesion count, but the effects are clinically significant, but high heterogeneity limits the certainty. Same with the total lesion count, where the range was 0.4 to -23. Again, lower values more improvement, higher values less improvement. 27 RCTs were included with a total of 5,500 patients, high heterogeneity. The outcome was the mean change in total lesion count. The placebo lowered the value by 15, the systemic probiotics by 23, topical antibiotics by 18, and topical retinoids by 14. These data are all clinically and statistically significant. All treatments reduce the total lesion count, and effects are clinically significant, but high heterogeneity limits certainty. So far, we are done with the figures and tables and working on the manuscript. We have some strengths and limitations. About the strengths, it is the first meta-analysis, including RCTs, and we had a large patient number. About the limitations, there was high heterogeneity, some interventions only qualitatively assessed, and combination treatments not evaluated. In conclusion, systemic probiotics have beneficial effect with good safety profile that has a similar effect to topical antibiotics. We should imply for practice because dermatologists should consider integrating systemic probiotics as adjuncts in acne treatment, and implication for research. Further research are needed to establish standardized dosing, duration, and application methods for probiotics. Now let me jump to the second topic about the efficacy and safety of different doses of isotretinoin treatment in acne. As I mentioned before, acne vulgaris is prevalent among approximately 80% of young adults. Oral isotretinoin monotherapy with success rates ranging from 85 to 90%. Its starting dose varies between 0.5 to 1 milligram per kilogram per day. Its side effects are mostly dose-dependent, such as dryness of the skin, increased cholesterol levels, and potential liver enzyme elevation. So far, we have two practices, the traditional practice and the modern practice. In the traditional practice, we were using high doses, shorter treatment duration, and strict monitoring. Meanwhile, in the modern practice, we use lower doses, longer treatment duration, and looser monitoring. So far, we have no consensus on standard dose and treatment length, checkup protocols, reported side effects, summer usage, depression impact, and checkup frequency. So my aim is to assess global practices and outcomes of the lowest effective dose of isotretinoin acne treatment. My clinical question is, which is the safest and most effective starting dose of isotretinoin treatment? That's why I've built a PICO framework, P being acne patients, administering them different doses of oral isotretinoin. The main outcome will be the change of disease activity, and the secondary outcome will refer to adverse events and compliance. My hypothesis is that lower doses of isotretinoin are as effective but safer than higher doses of isotretinoin treatment. If this turns out to be true, then we can standardize oral isotretinoin practices, improving safety, effectiveness, patient compliance, and satisfaction in acne treatment. We would like to collect some expert physician opinions about their individual patient data. We are interested in treatment details, side effects, mental health considerations, follow-up and monitoring, and treatment discontinuation. So to sum up, I would like to end my first project until September this year, and the second one until November 2026. I would like to end my presentation with the words from Thomas Edison: "I've not failed, I just found 10,000 ways that won't work." Thank you for your attention.
What are the possible side effects, what you were considering in your first project? What are the possible side effects of probiotics, for example?
Yes, usually probiotics are a safe option, but as every drug, they can have some possible side effects. Usually these refer to some abdominal discomfort like bloating, cramps, but allergic reactions can appear too because of the lactate or the soy components of the probiotics.
And how often these happen?
Data was referred to this, so every patient, the patients we included in the study were without side effects or adverse events.
You mentioned depression impact regarding isotretinoin treatment. Can you elaborate on that? What does that mean, or what are we afraid of, or where does that come from, that fear?
Yes. Some physicians think that depression can be related to isotretinoin usage, but there was no evidence-based reason for this, because first of all, we have to decide if we get the depression because of our disease, because of the acne, because it's unpleasant on our skin, or because it's treatment. So we have to measure these possible side effects also, but usually it's not because of the treatment.